Good afternoon, everyone, and thank you for joining us for this week's National Bleeding Disorders Foundation, formerly National Hemophilia Foundation, Wednesday webinar. My name is Fiona Robinson, and I am the series host. In today's webinar, we will go beyond the guidelines and explore some challenging scenarios of diagnosing von Willebrand disease, or VWD. We encourage you to ask any questions you may have today. You can ask your question by using the Q&A feature at the bottom of your screen at any time during the webinar. We will monitor these questions as they come in, and following our speakers' presentations, I will put your questions to them. This webinar is being recorded and will be available to the community beginning on Friday, November 10th. Today, we are joined by Dr. Yazan Abou-Ismail, who is an assistant professor of hematology at the University of Utah, and by Jasmine Pauldurai, an education specialist at the National Bleeding Disorders Foundation. I'd like to thank Dr. Abou-Ismail and Jasmine for joining us today. I'll turn things over now to Dr. Abou-Ismail to get us started.
Hello, everyone, and thank you, Fiona, for the introduction. I would like to welcome everyone joining us today for today's webinar. And I'd like to thank the National Bleeding Disorders Foundation for the opportunity to discuss this important topic today, which is how to diagnose and how to approach the complex diagnosis of von Willebrand disease. My outline for today will go over a little bit of a background, as well as how current guidelines recommend making the diagnosis of von Willebrand disease, as well as the diagnostic challenges and the factors that affect the laboratory assays that help determine the diagnosis, as well as the role of genetic testing. I have no relevant conflicts of interest to disclose. So a little bit of an introduction here. The diagnosis and recognition of von Willebrand disease is often challenging, and this is a worldwide and global issue, and that owes to several different factors. Importantly, there is often under-recognition of abnormal bleeding symptoms and ability to distinguish them from normal symptoms, as well as the issue with testing of von Willebrand factor level assays and methodology, and the complex nature of establishing the diagnosis of von Willebrand disease, owing to many different factors such as the impact of physiologic variables, and then the limitations of the genetic testing that is currently available. And in addition to that, there's other global issues such as lack of disease awareness among non-specialists, limited access to clinical resources in underserved areas, and so forth. And all of the above can lead to under-recognition and under-diagnosis of von Willebrand disease and a significant avoidable morbidity and healthcare system burden. So a little bit of background about both von Willebrand disease and von Willebrand factor. So von Willebrand disease is considered the most common inherited bleeding disorder and results from a quantitative or qualitative deficiency in von Willebrand factor, leading to various bleeding symptoms and bleeding complications that can affect daily activities, quality of life, procedures, surgeries, and childbirth, and is estimated to affect about 1% of the population, although it is likely underdiagnosed. And speaking of prevalence, the actual true prevalence of von Willebrand disease remains unclear for several reasons. The 1% figure that we often cite is based on population studies that looked at blood samples, although in other data, those who had clinically relevant disease and were seen in clinic was much less than that, was about 1 in 1,000. And a recent registry study that was published demonstrated that those who have a diagnosis in global registries were even far less than that, and estimated to be up to 3 per 10,000, and even much less so in geographic areas that were considered lower income. At the same time, a very recent study that was just published a month ago that looked at the genetic prevalence of pathogenic variants, particularly those that would cause autosomal dominant von Willebrand disease. When they looked at the genetic prevalence, they found a 13% genetic prevalence in the worldwide databases. And when they limited it to previously known pathogenic variant, that number was about 7% for type 1, as listed on the right side here, in addition to the other types. So there's a huge discrepancy here from what we see as a genetic prevalence, as population studies, and then those who actually end up in clinic and end up having an established diagnosis. And, the authors concluded that this probably suggests that von Willebrand disease is grossly underdiagnosed worldwide, which can be related to under-recognition of bleeding or lack of access to appropriate bleeding evaluation, and also the heterogeneous nature of the disease and the milder symptoms we often see. But most importantly, and which is the essence of my talk today, is the complex diagnosis and the diagnostic challenges that we face when we make the diagnosis of von Willebrand disease. Very briefly, and most people in the audience may be familiar with both von Willebrand factor and von Willebrand disease. So von Willebrand factor is a large multimeric glycoprotein that plays an important role or essential role in primary hemostasis as well as secondary hemostasis. So primary hemostasis refers to the role of von Willebrand factor in forming an adhesive bridge between the subendothelium and collagen and platelets. And this function is highly dependent on its size. And in addition to that function that leads to the formation of the platelet plug, von Willebrand factor also plays a role in secondary hemostasis, or the formation of the fibrin clot, due to its effects in helping stabilize factor VIII and preventing it from proteolysis by activated protein C and increasing its half-life. In addition to its roles in hemostasis, von Willebrand factor also has other roles and associations. So first, it can cause the opposite problem, which is thrombosis or blood clotting. In addition to that, von Willebrand factor can rise with inflammation, liver disease. There's been some association with von Willebrand factor and cancer metastasis and cancer microenvironment, as well as its role in vascular angiogenesis and atherosclerosis. And a very quick refresher on the subtypes of von Willebrand disease, which is relevant to how we diagnose this disease. Type 1 von Willebrand disease is the most common type of von Willebrand and results from a quantitative deficiency in von Willebrand factor. Type 1C is related to increased clearance, and then the type 2s are a qualitative defect in von Willebrand function, where type 2A and type 2B are related to loss of high molecular weight multimers. Type 2M is generally a platelet binding defect, and types 1, 2A, 2B, and 2M are inherited in a autosomal dominant fashion, generally, while types 2N and type 3 are generally inherited in an autosomal recessive fashion. Type 2N refers to von Willebrand disease that leads to a factor VIII binding defect, and type 3 von Willebrand is the most severe, typically often with undetectable levels and very severe clinical phenotype. So before we get into the diagnostic challenges, let's first review what the current guidelines are and how we currently make the diagnosis of von Willebrand disease. And here I'll be referring to the most recent 2021 guidelines that were evidence-based by the panel of the American Society of Hematology, ISTH, World Federation of Hemophilia, and as well the National Bleeding Disorders Foundation, formerly NHF. Based on the current evidence-based guidelines, the diagnosis is first determined when there's a clinical suspicion for a bleeding disorder, typically done by using a bleeding assessment tool. And then based on that, patients are screened for von Willebrand disease using the assays that measure von Willebrand factor antigen, platelet-dependent activity, and factor VIII. Those who have a level of less than 30 are then considered to have the disease, and those who have a level between 30 and 50 with a bleeding phenotype would also fulfill that criteria. We previously used to refer to this as low von Willebrand factor. However, this terminology has fallen out of favor, and we more often refer to them as mild type 1. Once the diagnosis of von Willebrand factor has been determined, the next step would be to determine what subtype of von Willebrand disease is diagnosed. And based on that, we determine first what the ratio of the antigen and activity to antigen is. So those who have a higher ratio are considered type 1, while those who have a lower activity to antigen ratio are considered a type 2. And then the panel recommends additional testing to determine which subtype of type 2 most fits the diagnosis. And essentially, the first step would be determining the multimer size, either by multimer analysis or a surrogate collagen binding to antigen ratio. And the guidelines also recommend the role of genetic testing that can help in the diagnosis of type 2B and type 2N as well. So when it comes to the diagnostic challenges that we face with von Willebrand disease, I do think of it as two main separate issues, or two main areas that we encounter globally. On one hand, recognizing the disease remains a challenge worldwide. So there is often under-recognition and under-diagnosis that owes to several different factors. One of them is the ability of both patients and clinicians evaluating them to be able to distinguish between normal and abnormal bleeding symptoms. And second of all, a very common presenting symptom, and probably one of the most common symptoms of von Willebrand disease, is heavy menstrual bleeding in women and menorrhagia. And very often, at least in my practice, I see that these symptoms are dismissed and not properly evaluated. And many times patients themselves are not aware that this is an abnormal issue, especially if it's something that runs in the family. And lastly, symptoms of von Willebrand disease vary. So there are patients who may have mild symptoms that may go for a long time under-recognized. In addition to that, access to resources is important. So in underserved areas or lower income countries, there's less access to clinics, laboratories that are trained, performing the necessary assays, limited awareness among non-specialists and patients, lack of proper evaluation. So all of these issues lead to a underdiagnosis or under-recognition of the disease before the patients make it to the screening process. Now, the other major issue that we face as a challenge in the diagnosis of von Willebrand disease is after testing is completed and after patients undergo a proper evaluation, very often establishing the diagnosis can be also complex and can be difficult. And that owes to several different factors as well, primarily the limitations of the plasma-based assays of von Willebrand factor. As I mentioned previously with the current guidelines, the levels of von Willebrand factors are an essential component of establishing the diagnosis. However, laboratory methodology and pre-analytical artifacts can often be a cause for inaccurate test results. And more importantly, physiologic variables can often affect von Willebrand factor levels. And that's something I will get into in the next slides. And lastly, the limitations of genetic testing. We don't yet have reliable genetic testing that can, quote unquote, confirm or rule out von Willebrand disease as we do with other conditions. It can in many instances. However, it has many limitations that I will also go over afterwards. So to address all of the above, the first thing I would like to stress is the importance of recognizing bleeding abnormalities. And this is something that is relevant for both patients and clinicians as well. And many such findings would warrant further investigation or at least an evaluation by a physician. So heavy menstrual bleeding, and I'll elaborate on that in the next slide. Cutaneous bleeding of 5 or more bruises that are more than 1 centimeter, is an abnormal finding. Similarly, prolonged bleeding from minor cutaneous wounds that would require frequent bandage changes. Epistaxis that requires intervention, meaning nosebleeds that need some sort of surgical procedure or in-clinic intervention, causing distress or affecting daily activities. Oral or gum bleeding lasting more than 10 minutes, dental extractions causing bleeding that would require a new office visit, surgical bleeding that is deemed too excessive by the surgeon. So all of these symptoms are necessary to be mentioned to the physician and warrant further investigation, as well as other bleeding symptoms that are more common in type 3. These would include GI bleeding, central nervous system bleeding, joint bleeds, muscle bleeds, and so forth. And we typically see bleeding symptoms more commonly in women than men in von Willebrand disease. And that owes to the hemostatic challenges of menstruation as well as childbirth that often present with symptoms more commonly in women. And on that topic, heavy menstrual bleeding is an important symptom to recognize. It is often under-recognized as an abnormality or sometimes dismissed or not properly evaluated. And here I use the definitions that were described by Connell et al. A couple of years ago. So any menstrual bleeding that lasts 8 days or more, or consistently soaks through one or more sanitary products every 2 hours on multiple days, or requires more than one sanitary protection at a time, or requires changing at night, or passing of blood clots, or has a pictorial blood assessment chart score of greater than 100. And this is what a PBAC looks like for those who are unfamiliar with it. And it's available either online or through your physician's office. All of these symptoms would constitute heavy menstrual bleeding. And that is something to mention to your physician and would warrant further evaluation as well. And on the topic of evaluation of bleeding symptoms, we often rely on bleeding assessment tools. And there's several that have been used historically. Typically, those of us in hematology practice, and those of us who are specialists have been more frequently using the ISTH bleeding assessment tool. However, this table here lays out the differences in the sensitivity, specificity, and duration it takes to administer each of these bleeding assessment tools. And the self-BAT is one designed for patients. Jasmine will be talking a little bit about that as well later on. And this is a very useful tool that's accessible to patients that they can use as a basic screening to determine whether there's abnormal bleeding symptoms that they should be concerned about. And this is an example of what the ISTH bleeding assessment tool, which is meant for physicians, looks like. And this is something that can be used in the primary care setting. So even those who are seeing their primary care doctor for an issue can discuss that with them, and the PCP can use this tool as a screening method. So in addition to recognizing abnormal bleeding symptoms and properly evaluating them, the second major component of establishing the diagnosis of von Willebrand disease is the laboratory component. And that heavily relies on the von Willebrand factor assays that measure its levels and activity through plasma-based assays. So very briefly, the standard assays that we use upfront for von Willebrand disease evaluation or screening includes the antigen, which looks at the quantitative amount of von Willebrand factor levels, and then the platelet binding activity, which most frequently labs and institutions will use the ristocetin cofactor. However, there are newer assays that are available to look at platelet binding activity and factor VIII. In addition to that, there are supplemental tests, including multimer analysis, collagen binding, factor VIII binding, von Willebrand factor propeptide, and ristocetin-induced platelet aggregation, all of which have their roles and use in finalizing and confirming the diagnosis and subtype of von Willebrand disease. And because the diagnosis of von Willebrand disease is very heavily reliant on laboratory assays, it is very crucial that these assays are performed correctly. And that's a major cause for artifact or error that can complicate the diagnosis. And so very briefly, it's important to note that different types of artifacts can cause laboratory errors. So whole blood refrigeration can reduce the measured amount of Willebrand factor and factor VIII. And very minor things such as excessive tourniquet use, the size of the needle bore, underfilling or overfilling the coagulation tube, presence of heparin, or having a high hematocrit, all of these things can either overestimate or underestimate the levels of von Willebrand factor. And so it's important to try to minimize as much as possible the analytical or pre-analytical causes for error. And that means that we generally recommend that whenever possible, specialized staff and a specialized laboratory using a fresh sample and trained in appropriate methodology and adjusting for potential pre-analytical events is generally recommended to make sure the assays are as accurate as possible, and also repeating the testing to either confirm or rule out the diagnosis rather than relying on a single sample. Now, the platelet binding activity, which is one of the cornerstones of the evaluation of von Willebrand disease, has historically been more frequently dependent on the von Willebrand factor, RISTA-C, and cofactor assay. However, we do have newer assays that are available. And I want to briefly comment here on the distinction between the two. So the RISTA-C and cofactor has a high coefficient of variation, meaning that the results can differ even from day to day, has poor sensitivity, can be affected by the PD1472 variant that is common in those with African ancestry, as well, and a result of that can either underdiagnose or overdiagnose von Willebrand disease. On the other hand, the newer assays, the GP1BM and the GP1BR, have greater precision, and they're more sensitive to lower limits of detection and have an excellent coefficient of variation and are unaffected by the D1472 variant. And so the 2021 guidelines recommend that we use the newer assays whenever available, owing to these differences. And here I want to very briefly comment on collagen binding. And the collagen binding assay is an assay that we're more frequently using in the evaluation of von Willebrand disease. And so as a recap here, von Willebrand's ability to bind collagen is essential for its hemostatic role and is dependent on high molecular weight multimers. And including collagen binding in the evaluation for von Willebrand disease can have a dual role. The ratio of collagen binding and the antigen can serve as a surrogate for multimer analysis. And at the same time, there is increasing interest in whether there could be a specific collagen binding defect that would occur as a result of a mutation in the von Willebrand factor gene binding sites, A1 or A3, where the protein would bind to collagen. So if there's a mutation there and von Willebrand factor has a defect in being able to bind to collagen appropriately, that rather than just platelets that we normally test for, then this assay could potentially assess for such a defect. And this has been described and has been associated with increased bleeding. And currently the collagen assays use either type 1 or type 3 combination, or type 4, type 6, which is not commercially available. And a question that often comes up is, what if the antigen is normal and the platelet binding activity is normal, but the collagen binding abnormality is the only detectable abnormality when evaluating a patient? Up until today, this still remains uncertain on how to diagnose or manage these patients. And there are those who consider this to be a unique entity under the category of type 2M collagen binding defect, although this is not agreed upon in the hematology world. And so currently there is no consensus or guidance on to make a diagnosis of von Willebrand disease based on an isolated collagen binding abnormality when everything else is normal. However, as we continue to learn about this could still be clinically considered as a diagnosis for those who do have a clear bleeding phenotype, where this is a consistent laboratory abnormality. Now, an important aspect of the assays that measure von Willebrand factor levels and activity is understanding that these numbers are often very heavily impacted by physiologic factors. And in this diagram here, my colleagues and I outline the different physiologic factors that may either increase or decrease the levels of von Willebrand factor levels. And so an important distinction here to make is that a lot of these issues are common. Atherosclerosis, inflammation, liver disease, aging, estrogen, and so on. And so it's important to recognize that there's physiologic factors that can impact the levels and thus impact the diagnosis. And I also want to briefly mention blood type O here, which has been shown to be associated with lower levels of von Willebrand factor. And an estimated 14% of them may have levels less than 50, although typically without increased bleeding. So I'd like to highlight some of these physiologic factors, or at least the most important ones. Beginning with inflammation. So von Willebrand factor and factor VIII are acute phase reactants, which means that they will rise with inflammation typically, and often a 3 to 5-fold rise. So it's important when evaluating the patient to consider any recent or ongoing active inflammatory process, such as infection, trauma, surgery, chronic illness, autoimmunity, and what have you. And sometimes measuring a CRP level may help uncover an occult inflammatory process. So if there is a reversible inflammatory condition, such as an acute illness or recent infection or recent surgery, then it's important to wait for its resolution and then repeat testing afterwards so that the test results are not confounded by inflammation. However, there are other cases such as malignancy or chronic illnesses where the inflammation is ongoing and chronic. And in these situations, the diagnosis remains a challenge. One thing to consider is that patients with an active inflammatory process would be expected to have supranormal or high von Willebrand factor levels above the normal range. And if they are in the low normal range and there's a bleeding phenotype and evidence of inflammation, it's possible that the latter could have confounded von Willebrand factor levels. So it's important to ensure accurate assays as much as possible, or evaluate for alternative causes if the levels are consistently normal. And in some cases, consider genetic testing, which I will elaborate on afterwards. Another potential confounding factor is estrogen. So high estrogen levels can increase von Willebrand factor levels significantly. And so it's important to repeat testing when patients are not pregnant or not on replacement therapy that has high levels of estrogen. Oral contraceptives nowadays don't contain significant amounts of estrogen and are not expected to increase levels significantly, so we don't typically ask to stop it. However, this can be considered for the borderline challenging cases. Similarly, we don't typically recommend timing the testing in relation to the menstrual cycle, although we do see here in the diagram that in the mid-follicular phase, there is a rise of von Willebrand factor levels. So sometimes when the diagnosis is a challenge and there's low borderline levels, we can consider timing it to the onset of menses where the levels are at their lowest. And then aging has been demonstrated to be associated with increasing levels of von Willebrand factor and factor VIII, but it remains unclear whether the normalization of VWF levels in older patients results in decreased bleeding symptoms or not. It's possible that that may be the case for some, but not everyone. And so that remains another challenge on whether the diagnosis resolves with age in those who normalize their levels or not. And I think some do and some don't, and that's a clinical evaluation. And for that reason, the 2021 guidelines suggest reconsidering, but not removing the diagnosis in those who normalize their levels. So to recap on those who do have borderline levels, although ranges in the 50 to 60 have been described to be associated with bleeding in some data, that doesn't fulfill the diagnostic criteria. So those who do have low normal levels and bleeding symptoms, it's important to ensure that, one, the diagnosis is as accurate as possible, meaning that the laboratory methodology is accurate and errors are minimized and the labs are performed in a specialized expert lab. and two, to evaluate for any confounding physiologic factors that can significantly impact von Willebrand factor levels, as I mentioned previously, and to recheck after resolution of any active or acute inflammation. And third, there is a role for genetic testing in select cases. And that's the next part that I want to elaborate on with our remaining time. So very briefly, the gene encoding von Willebrand factor is highly polymorphic. It's located on the short arm of chromosome 12 and has many pathogenic variants identified, more than 500. However, it is often difficult to distinguish between pathogenic variants or those that may be benign, particularly in type 1 or those with mild type 1. And this can lead to misclassification of sequence variants. And so previously pathogenic variants have been seen in healthy individuals and vice versa. So the inability to determine whether a variant is disease-causing or benign is a challenge and is related to incomplete knowledge of the gene and protein function. There is NGS test, next-generation sequencing testing, that can either look at the whole genome, the whole exome, or sequence target panels. And it will classify, based on best available information, any identifiable variants as either pathogenic, likely pathogenic, or a variant of uncertain significance, VUS, likely benign, or benign. And that's typically what the test results will show us. And so for that reason, only about 62% of type 1 von Willebrand have an identifiable pathogenic sequence variant, and even less so for mild type 1. And as a result of that, there is limited utility currently in the routine evaluation of genetic testing in von Willebrand disease, but it does have its uses. So it can be helpful in distinguishing type 2N versus mild hemophilia A, or type 2B versus platelet type von Willebrand disease, or type 3 versus severe type 1, and so forth. So it has a role in identifying the subtype in many instances. And so there's proponents and opponents of the regular use of genetic testing. I think one of the cons is that it's not widely available, and the challenge in distinguishing between benign and pathogenic variants, and the inability to know how to interpret VUS findings, as well as cost. However, it does have advantages in certain cases. So it can be useful in distinguishing subtypes, as I mentioned, and it is also not influenced by physiology, as opposed to the plasma-based assays that measure von Willebrand factor levels. And it's uncomplicated in terms of sample shipment. It can also help identify family members, or it can detect the D4072 variant in those where it is suspected. And another potential advantage is that it has the ability to assess for several genes implicated in hemostasis when the target gene panels are used in those who have a bleeding of unclear cause, or BDUC. So those who have a bleeding phenotype, and we've evaluated for alternative causes and may have low borderline von Willebrand factor levels, it may serve a dual cause here in determining whether there could be a pathogenic von Willebrand disease variant, or potentially a different bleeding disorder. So in summary, von Willebrand disease is likely significantly underdiagnosed worldwide, owing to both under-recognition as well as the complex diagnosis of the disease and limitations of laboratory assays. Proper diagnosis can prevent morbidity and healthcare system burden, and the recognition and proper evaluation of bleeding symptoms is crucial. Bleeding assessment tools are incredibly helpful for both patients and clinicians. The diagnosis of von Willebrand disease can be challenging due to the physiologic factors that impact von Willebrand factor levels and the limitations of these assays. Before ruling out von Willebrand disease, it's important to ensure accuracy of laboratory testing and methodology, and to utilize expert labs whenever possible. And it's also very important to assess for confounding physiologic factors, such as active or ongoing inflammatory conditions, and the clinical setting at the time of testing. Genetic testing may be beneficial in certain cases and may have a role. However, its use remains limited to the highly polymorphic nature of the von Willebrand factor gene. And lastly, it's important to consider workup for alternative hemostatic defects or disorders in those who have a significant bleeding phenotype. Thank you for listening, and these are my references. And I would like to hand it over to Jasmine now, who will talk to us a little bit more about resources for patients.
Thank you, Dr. Abou-Ismail. Share my screen as soon as you wrap up your screen share. Thank you. All right. Hi, everyone. My name is Jasmine Pauldurai. I'm an education specialist at the National Bleeding Disorders Foundation, and I am here to chat about Better You Know, which is one of our programs that we offer the undiagnosed community to kind of help you through that diagnostic journey that Dr. Abou-Ismail was speaking about. So what exactly is Better You Know? Better You Know is a program that we've created for women, girls, and people with potential to menstruate who are experiencing signs and symptoms of a bleeding disorder, but haven't yet received a diagnosis. So it's for our undiagnosed community. And while I'll spend some time talking about our website, which is the bulk of what we have to offer, the program does go beyond just a website. We also have sessions at BDC and even published an article with Clue, the period tracking app, this past year. But our website is our landing page for most of the key resources that we have to offer, as well as a risk assessment tool that I'll chat about in just a second. So our validated risk assessment tool asks just a few quick questions to gauge whether you're at risk for a bleeding disorder. So the assessment is not a diagnostic tool. It can't tell you for sure or give you a clear-cut answer if you have a bleeding disorder, but it's a really great first step to strike up that conversation with your provider. So we actually often recommend printing out the results that you get at the end of your assessment and bringing that with you to your appointment. So bringing it to your provider and, again, starting up that conversation with them. So over the past few years, we've had over 18,000 responses to our risk assessment form, with about 5,000 just in this past year. And what we found is that nearly 80% of women taking our risk assessment form are receiving an at-risk result, meaning that they're experiencing signs and symptoms of a bleeding disorder and haven't received a diagnosis. So that's an issue, right? So we want to encourage them to strike up this conversation with their care team to see if they have a bleeding disorder, to be able to receive that diagnosis, and ultimately just to get the care and treatment that they deserve. So our website also houses our printable and downloadable PDF resources. So I have a QR code right there that will take you right to those resources. I've highlighted just a couple here. We have our menstrual chart and scoring system that helps you quantify the number of pads and tampons that you're running through in a cycle. And again, a really great resource to print out, fill out, and bring with you to your appointment to get that conversation started with your provider. I also have our healthcare diary pointed out over here that runs through some of the common questions your provider might ask you at an appointment and helps you prep for upcoming appointments. But we also have more resources on our page as well. For example, we have a lab testing log that breaks down some of the diagnostic testing you might go through, as well as a pamphlet that we have for OBGYNs. Also important to note that all of these resources are available in both English and Spanish. We have a little toggle at the top of our website that if you had pressed the little Spanish button, all of the resources will populate in Spanish. So I did want to play a really quick video, a snippet of one of the videos that we have on Better You Know as one of our resources, just to highlight why it's so important to seek out a diagnosis. So you'll hear a couple stories, why it's so important to be on this journey.
So I wasn't diagnosed until I was 16, but all of my symptoms started when I was 9.
I was diagnosed when I was 7.
11 years old.
I started to show symptoms in middle school.
I was diagnosed at 30. The doctors they didn't know what it was. Like, I did have symptoms, but they thought I just had heavy periods.
I can do anything, anytime, anywhere.
I can do everything everyone else does. I do classes for aerial silks right now.
And I exercise.
I've skydived.
Dance, some people think that it's dangerous when you do leaps, but actually it gives more strength into my joints.
And I'm empowered because I know.
I love that video because you can tell just how important it was for some of the women in this story to seek out that diagnosis, to stick it through this journey and make sure they were getting a diagnosis. So I want to switch over to Journey to Know, which is a program that we launched actually as part of Better You Know in August of 2022. So as many people in this community can probably attest to, the diagnostic journey can be long, it can be confusing, and it also never looks the same from one person to the next. So the goal of this program is to shed some light on some of the next steps you should be taking when seeking out a bleeding disorder diagnosis, and to walk users through that journey together, along with some resources and some helpful videos, all in an effort to make this journey seem much less confusing, much less daunting. So what you'll be getting out of the Journey to Know program is we have two main components here. We have the Stay in the Know and we have Watch and Know. So Watch and Know is what I've highlighted on the left side of this PowerPoint here. We've created 8 videos in-house that we filmed, starting with what's next. And they kind of take you through this diagnostic journey, right? So what's next will take you from the first moments you realize that you have signs and symptoms of a bleeding disorder. For example, if you took the risk assessment tool and realized you have signs and symptoms of a bleeding disorder, all the way up until booking that appointment. What are those next steps? What does that look like? You have a ton of questions. What does that process look like? That we've highlighted in that first video. We also have a video called Bleeding What that talks about signs and symptoms of bleeding disorder, kind of breaks down some of the terminology. And then we also have 3 videos that talk about what communication with providers can look like. We have communicating with a healthcare provider, communicating with an OBGYN, and communicating with a hematologist. And so it walks through basically what those appointments could look like, what types of questions should you be asking, what types of questions could they be asking you, what to prepare for those appointments, how to advocate for your needs, talk about your signs and symptoms, and ultimately make sure you're getting the testing that you need. We also have a video called All About HTCs. For people who are newer to this community, we wanted to make sure to highlight all of the amazing resources that we have available at our HTCs. And then we have our Stay in the Know component, which is an email and or SMS check-in. You can sign up for either email or SMS or both to kind of assist you and guide you through this diagnostic journey. So as you can see on the right, there's a sample message there. It walks you through this journey over 12 weeks. You'll get a message every 2 days approximately that send you some resources, some of those videos that are highlighted in Watch and Know. Those will be interspersed throughout the program, as well as just a guide, some check-ins of like, how are you doing in this process? Were you able to book an appointment? What are some obstacles you're facing? And how can we help you? So we kind of just want to be there for support along this journey, again, to make this process less confusing. And then some great news is that Journey to Know will be launching in Spanish in 2024. As I mentioned earlier, our resources are available in both English and Spanish, so it was important to us to be able to release Journey to Know in Spanish as well. When we first released in August 2022, it was only in English, but we're working on recreating all of those 8 videos. The content will look a little bit similar, but it will be a little more culturally relevant. And then that Stay in the Know element. So the SMS and email component will all be translated into Spanish and will be set to launch in 2024. So stay tuned. And with that, I would like to thank you all for your time here for listening about Better You Know. I've included our website here. I really do encourage you to check out betteryouKnow.org, print those resources, fill them out, share them with a friend, a loved one, and as well as that risk assessment tool, share it with anyone you think it could be beneficial to. And then if you have any questions at all, please send us an email at byk@hemophilia.org. With that, I'd like to thank you once again and hand this over to Fiona.
Super. Thank you very much. Thank you for this really interesting presentation, both of you. We will go ahead now with our live Q&A. Just a reminder to our audience, if you have a question for our speakers today, please enter it in the Q&A feature at the bottom of your screen. We will do our best to answer all of your questions. We had a question come in from an audience member. Actually, I know this is a diagnosis discussion primarily, but they were asking if you could maybe just briefly go over what are the current treatments for VWD?
Yeah, that's a great question. The treatment of von Willebrand disease is first determined by what type of von Willebrand disease the patient has. and what type of bleeding symptoms or what the clinical setting is. For example, is it someone who is asymptomatic but is planning to have a surgery or some sort of procedure, or someone who has chronic recurrent bleeding symptoms such as heavy menstrual bleeding. So we do have different types of treatments available. Von Willebrand factor replacement, so supplementing with a product that contains von Willebrand factor, is something we commonly use for those who have type 2 or type 3 or require some sort of surgical intervention. And then desmopressin, or DDAVP, is a type of treatment that raises the levels of von Willebrand factor by promoting endogenous production of von Willebrand factor. And this is something that's the patients have to be tested for to make sure that it is effective for them. And typically we use that for type 1 patients who are requiring either a minor procedure or have a minor bleed, and can also be used in the management of heavy menstrual bleeding. And then we also often use a medication called tranexamic acid, or Listida. This is a medication that helps blood clots survive longer or slows down the degradation of blood clots. And we use that as an adjunct for minor procedures in those who have mild bleeding symptoms, and also can be used in controlling heavy menstrual bleeding. And so depending on the type of von Willebrand disease, whether it's a type 1 or a severe type 3 or a qualitative defect, that will determine what the best treatment option is, in addition to the bleeding symptoms and the clinical scenario and the clinical situation. And lastly, for type 3 patients who have very severe and recurrent bleeding, many of these patients may be eligible for prophylaxis. So these are the types of treatment that we give regularly rather than on an on-demand basis.
Great. Okay. So quite a few options, but also quite dependent on the diagnosis.
Correct.
Right. Interesting. Another question we've received from our audience was somebody asking if you could explain the difference between genotype and phenotype.
Yeah, that's a great question. So genotype refers to the genetic abnormality that we can detect in genetic testing. So the genotype in someone with a autosomal dominant von Willebrand disease, such as type 1, would demonstrate that there's a genetic defect in one of the alleles. So there's 2 copies that we inherit from our parents. And so the genotype will demonstrate how many of these copies have a genetic mutation and whether that genetic mutation is benign or pathogenic, meaning that it's a disease-causing mutation. So that's the genotype. The phenotype is the clinical manifestation of that genetic abnormality. So in other words, what are the von Willebrand factor levels that we see that we can measure in the blood and the protein amount, and also what the clinical symptoms are. So is the bleeding heavy, severe, and so forth. So the genotype is what the genetic abnormality is, and the phenotype is the clinical result of that genetic abnormality.
Right. Okay. So I know in hemophilia, they talk a lot about like the level of factor you have, and that corresponds to the severity of the bleeding. Does that, I mean, I know there's some variability in that as well, but is that also the case for VWD? Is there a correlation between activity or factor levels and bleeding phenotypes, or does that work the same?
Yes, so there is a correlation between the levels of von Willebrand factor and the bleeding symptoms. And in fact, this has been demonstrated in the past, where they graphed the levels of von Willebrand factor along with bleeding assessment tool scores. And so there is a correlation, which is why we do often rely on it. That being said, we often do see heterogeneity or variability in how patients present. So we often see that some patients with certain level may bleed more than others, and vice versa. So while there is a correlation, there is also variability in our patient populations owing to many different factors.
Right. And you mentioned the bleeding assessment tools, the BATs. There's a number of different BATs. So is there a preferred BAT, or are there preferred BATs for different contexts? Do you have a favorite BAT?
Yeah, that's a great question. So each of the BATs differ amongst each other by, first of all, the sensitivity, specificity, and also the ease of use, or the duration of time it takes to conduct the BAT. My favorite BAT is the ISTH BAT, because it's a great balance of having great specificity and a reasonably short time to administer compared to other BATs. And I feel that this has, fallen into preference or gone into preference among hematologists nowadays. In addition to the self-bath, which is a very useful tool for patients, which is available online, that can at least help them bring up the conversation with their clinician or provider to ask about whether there's additional evaluation that is needed.
Another question that's come from an audience member is asking whether being on hormonal contraception can impact the diagnosis and I guess through the levels of VWF.
Yeah, that's a great question. And I tried to elaborate on that a little bit, but I kind of rushed through the slide as I was running out of time. But nowadays, the oral contraceptives that are available commercially contain lower levels of estrogen. And so typically, they don't impact levels significantly. They can impact them a little bit, though. So most of the time, our practice is not to discontinue the oral contraceptive and still perform the testing while on it. There are situations, however, where there's a bleeding disorder and we're having difficulty determining that diagnosis, and we want to sort of really eliminate any potential confounder, even if it's a small confounding effect. So that would be a situation where I'd consider holding an oral contraceptive. Most of the time, though, nowadays, we don't need to hold it because the impact is not that significant.
Right. Okay. That makes sense. A couple of questions for you, Jasmine. We've had a question from an audience member, whether there are any better resources for males.
Yes, I can absolutely take that. So yes, short answer, yes. So if you go over to betteryouknow.org, you'll see that on our main page, it says, I want to know for women or I want to know for men. And so we have our self-risk assessment tool for women and for men. So you can take that risk assessment tool for men. And then a lot of our resources are also generalizable. We have a little bit of something for everyone. So for example, that lab testing log, that kind of breaks down some of the terminology you might hear when seeking out a diagnosis. That is for everyone. We also have some of our pamphlets on prepping for an appointment that could be used for everyone. So I'd like to think we have a little bit of something for everyone on the webpage.
Great, great. And you mentioned also that quite a few of them are either available in Spanish or you're working to translate them. What about other languages? Are there any available in other languages? Or if I had a group that maybe wanted to translate some of the resources, are there opportunities to do that, ways that can be done?
Absolutely. Send them our way, please. We would love to expand to other languages. We currently only offer in English and Spanish, but we are trying to make this as accessible as possible. So please do let us know if you'd like to see it in other languages, and we can hopefully make that work in the future.
Super. I have another question going back into the introduction. Dr. Abou-Ismail, you spoke about VWF and I think cancer and some kind of an association or relationship there. Is that something that you can expand on a bit?
Yeah, there's growing amount of evidence that shows that the tumor microenvironment, so that's the niche where tumor cells can grow and perhaps eventually allow them to metastasize, have demonstrated that there's presence in von Willebrand factor in these types of tumor microenvironments. And this is early data, but there's some evidence to suggest that perhaps certain types of cancers may rely on von Willebrand factor for angiogenesis, or the formation of blood vessels, which in turn may be something that is associated with cancer metastasis or cancer growth and development, owing to certain factors that are present in the tumor microenvironment, such as von Willebrand factor. So there's some association there that is being investigated, and we continue to learn more about it.
And maybe I'll just make this one of our last sort of formal questions, but let's say somebody doesn't have a diagnosis, but they are experiencing bleeding symptoms. How can they advocate for the appropriate testing?
Yeah, that's a great question. So, the first important thing is, awareness among patients on what symptoms are considered abnormal bleeding symptoms that should be raised with a clinician or provider. And so in addition to patient advocacy efforts and resources such as the ones Jasmine has described, when patients have that suspicion, it's important to just ask your provider about it, ask a clinician or primary care doctor, and bring it up as a symptom. Mention that, hey, I've noticed that maybe I have a lot of bruising, I have a heavy periods, etc. Is that something to be concerned about? And then, so I do encourage patients to just relay these concerns. And many times I find that patients, have had these symptoms their whole lives and don't know that they're abnormal, or perhaps it runs in the family and everyone in the family has heavy periods, so they kind of brush it off. So it's important that, when in doubt, just ask your doctor, and when this is brought up to your doctor, they'll be able to evaluate you to determine whether this is a concern or not, and that would eventually lead to either testing or just reassurance.
And another scenario that someone's asked about is, for example, if someone has been diagnosed with type 1 VWD and then as years have gone by, gotten undiagnosed. So I guess, if the levels kind of come up a bit, or but they still have bleeding phenotype, they still have issues with excessive bleeding. What can they do? Because without the diagnosis, there's not access to treatment. So what do they do in that situation?
Yeah, that's a great question, and something we do often see in clinic. And just to kind of refresh a little bit what I had described earlier. So certain factors may elevate von Willebrand factor levels, such as inflammation, infection, surgery, and new chronic illness that developed, and something just as simple as aging itself, just normal healthy aging. We've shown in our large study a few years back that about a third, or 20 to 30% of these patients may normalize their levels as they get older. Pregnancy itself can normalize the levels. So there's different things that can normalize the levels. So the first important thing is to make sure that the initial diagnosis was accurate and that the patient really does have von Willebrand disease, and it wasn't the other way around, that their levels are normal and the low one was the false one. So it's important to make sure that the initial diagnosis was correct. If it is correct and then levels normalized with time, this has to be evaluated by an expert to determine, is this some sort of artifact? Is there a confounding variable we can control for? Or is it just due to a new chronic process, such as chronic illness or aging? And in that setting, we have conflicting evidence on whether a normalized level does actually result in less bleeding or not. And we've seen evidence of both scenarios. So there are patients who've normalized their levels and continue to have bleeding. In these situations, this is a clinical diagnosis and a clinical management that should be performed by an expert and a specialist in hemostasis and bleeding disorders, where we determine that the patient who does have von Willebrand disease and normalize their levels, if they clinically continue to have bleeding symptoms, then that is an indication for them to receive treatment to prevent bleeding from surgeries or procedures or ongoing bleeding symptoms. So an expert would have to make that determination that the normalized levels did not, in fact, result in an amelioration of the bleeding symptoms or resolution of the von Willebrand disease diagnosis. So we would continue to maintain that diagnosis for them and allow them to receive necessary treatments.
Right. Okay. I see. Well, thank you. Thank you very much for answering those questions, both of you. To wrap up our Q&A session, we'd like to ask our audience to answer a few questions. So I'm just going to set a poll here for you. And you should see now 3 anonymous polling questions. We would really appreciate it if all of our audience members can take a moment to answer those questions, and just note that the answers are collected anonymously. And as we give everyone a few minutes to answer those questions, I would like to thank Dr. Abou-Ismail and Jasmine for sharing your time and your expertise with us this afternoon. I'd also really like to thank Takeda, whose generous support made today's webinar possible. And I'd like to thank each of you in our audience for joining us. This recorded
Thank you so
webinar.
much for having us.
This recorded webinar will be available on Friday, November 10th at hemophilia.org under the Events tab. If you select past events, you will find all of our archived webinars there. Also available in the Events tab is the schedule of upcoming events in this series. Join us next week when a panel of lived experience experts will discuss Untold Journeys, a glimpse into ultra-rare bleeding disorders. And I'm just going to end our poll and say thank you very much to everybody for joining us this week, and have an excellent week.
Thanks for having us. Thanks everyone for joining.
Thanks everyone.